Hi, good evening, everyone. My name is Jason, and I'm the Medical Affairs Manager for Nestle Health Science. On behalf of my team, I would like to welcome and thank you for joining our standalone webinar on medical nutrition for critically ill. We are very fortunate this evening to be able to invite Dr. Jonathan Tan, who was the previous president of SINGSPEN, to chair the event, and also Dr. Stephen McClave, who is a world-renowned expert in this field, to speak for us. I hope to quickly go through some housekeeping so as not to interrupt the lecture. All audience will have their mic muted by default. Next, we strongly encourage our audience to ask our speaker questions, and you can do so by typing it into the Q&A chat box provided in the Zoom user interface. If for some reason you can't view the slides or the screen turns white, please log off and log in again, and the issue should be resolved. And finally, we hope that you can please help us to fill up the feedback form that will pop up at the end of the webinar. So that is all from my end. We hope that you will enjoy this session and learn something that could be put into good use in your clinical practice. Without further ado, I shall pass the floor to our chairperson for the evening, Dr. Jonathan Tan. Dr. Tan, to you.
Okay. Hi, everybody. Well, good morning or good evening to all of you, wherever you are, whether it's a nice breakfast or if you're in Singapore, a nice beer to end the day. I know, perhaps some people have beers to start the morning. I don't know, but whatever is your favorite tipple, I'm glad that you're here with us because you are extremely privileged. Today we're going to talk about and discuss optimizing nutritional therapy in hospitalized patients and in particular in critically ill patients. And we're extremely privileged to have Professor Stephen McClave. Professor McClave, I'm sure all of you would have heard of the SINGSPEN guidelines for critical care nutrition. And if you have, you would know that Professor McClave, who is the lead author in the 2009 and 2016 versions, as well as today, you're really in for a treat because he's going to share with us some insights from the 2021 edition as well. So Professor McClave, as you all know, is an expert in medical nutrition, and it has been his passion, and he's been actively involved writing and educating all of us, as well as being a past president of SINGSPEN as well. So, and he's still very active in medical nutrition therapy in Louisville. So without further ado, let's have Professor Stephen McClave talk to us. Thank you very much, Professor.
Thank you. Thank you, Dr. Tan. Here you go. It's a joy to join this session, and it's very well organized with Jason and Dr. Tan. It is 7 a.m. here in America, it's 7 p.m. there in Singapore. So thank you for sharing your evening with us this morning. We're going to be talking about various issues in traditional critical care nutrition, and then we'll show throughout the talk how COVID-19 changes that paradigm and throws up barriers to what we're trying to do for our patients. Here are my objectives. First, I want to talk about understanding how the breakdown of gut barrier defenses and loss of the commensal microbiome impact changes in the ICU. I hope you'll appreciate the controversies in dosing the protein and the calories for our ICU patients. We then need to understand how COVID-19 is unique and different from our traditional ICU patients, and how the constraints of this disease process impact the delivery of nutritional therapy. And then finally, and most importantly, we need to appreciate strategies in nutrition that will help maintain gut defenses and support the microbiome, because if we do that, we're most likely to change outcome. And these are my disclosures. Now, when a patient comes into the ICU and they're critically ill, they're actually in a balance, and the gut affords us an opportunity to alter outcome. And the reason it can alter outcome is because it's the largest immune organ and has the greatest microbial burden. With critical illness, there is a pathophysiologic pressure that drives our patients toward the right on this scale, in which there's a pattern of inflammation, dysbiosis, in which the bacteria in the gut become virulent and attack the host, and it's a increased permeability, breakdown of defenses, the bloom of these virulent pathobiomes. And in this situation, the gut becomes an accelerator and actually contributes to worsening organ failure and even mortality. That same organ can be utilized to reverse this process or move us in the opposite direction by initiating early enteral feeding, by adding fiber, by doing certain things through the gut. We can support the refaunation of the friendly commensal bacteria. We can reestablish barrier function. We can create symbiosis in which we have a friendly benefit from the microbes in the gut, and we can restore homeostasis. So this talk will show how strategies with nutritional therapy can shift the patient on this scale. This is not a phenomena of lab rats in a laboratory. These changes and this shift has been documented in patients with pancreatitis, with surgical sepsis, and as I'll show you today, in COVID-19. Now, in health and homeostasis, there's an important crosstalk signaling between commensal friendly bacteria in the gut and the epithelial surface. The commensal bacteria don't have the machinery to attach or adhere to the epithelium, so we're talking about pieces of the commensal bacteria, their cell wall, their flagella, the endotoxin. And these pieces of the commensal bacteria will bind to toll-like and nod-like receptors on the gut epithelium. And depending on which cell they bind to, you get a different benefit in barrier defense. So binding to an intestinal epithelial cell will increase tight junction proteins, and the junctions will get tighter and less permeable. Binding to goblet cells increases mucus production. It gets thicker and thicker. Binding to Paneth cells will increase the release of defensins into the lumen of the gut. And these are proteins that bind to the pathogens and carry them out in the stool. And then binding to the dendritic cells will affect T cell differentiation in a regulatory manner for appropriate immune responses. In critical illness, all this changes and there's disruption of barrier function. The initial thing is a dynamic functional increase in permeability. Then you get these big defects from apoptosis, in which there's death of these epithelial cells, and now there are big defects in barrier wall. The normal mechanisms that would repair this are compromised. The microbes can now penetrate more easily into the submucosa, where it engages receptors on the dendritic cells and on the opposite side of the epithelium. There's thinning of the mucus layer, and this toxic gut-derived lymph is formed that actually gains access to the systemic circulation and leads to multiple organ failure. And then the once commensal bacteria now shift, and there's the induction of virulence and the bloom of virulent pathogens. The signaling changes the immune response from the gut. So in health and homeostasis, it's the pieces of the commensal bacteria called MAMPs, microbial associated molecular pattern. Those pieces binding to the dendritic cell lead to a line of anti-inflammatory Th2 and T regulatory cells. But with critical illness, the binding shifts, and it's the pathogens themselves, PAMPs, or pieces of necrotic cells, microbial DNA, mitochondrial DNA called danger-associated molecular pattern. Now these PAMPs and DAMPs are binding to the dendritic cell, and a different line of cells emerge from the gut that are pro-inflammatory, Th1 and Th17. So you get a shift from homeostasis to critical illness, and different pro-inflammatory cells emerge from the gut. What does this look like at the bedside? This is what we call immune dysregulation or gut sepsis. The patient looks like they're septic, but there's no pocket of pus, there's no pneumonia, the urine's clear, and this process is originating from the gut. There's the bloom of the pathobionts, and this is wild. When you're critically ill, within 6 hours of onset of trauma or sepsis or critical illness, you get 90% of the commensal bacteria disappear. They're either killed outright or they're sequestered in various parts of the body, and you lose biodiversity. And the pathogens that are already there go from a commensal lifestyle or phenotype to a virulent phenotype. And this is Pseudomonas in the commensal type and the virulent type. This changes their behavior, and they will adhere to the epithelium of the gut. They will establish a biofilm, and they may actually launch a full attack on the epithelium. The crazy thing is they can pass in and out of virulence. They become angry because there's no low oxygen or no nutrients or no phosphate. But if we restore oxygen, if we give them nutrients, if we give them phosphate, they will come back out of virulence and go back to being commensal. That's how nutritional therapy can modulate this part of the process. What does this virulence look like at the bedside? It's septic morbidity. It's the emergence of toxic lymph that leads to organ failure, and all this contributes to antibiotic resistance. Now, the toxic lymph is interesting. We've known for years in lab animals that there was something emerging from the gut through the lymphatic channels, not the portal vein, but through the lymphatic channels in the thoracic duct. And if we ligated the thoracic duct, we could protect lab animals against respiratory failure and multiple organ failure. For a long time, we looked at it, we thought it was bacteria. It wasn't endotoxin, cytokines. It was none of those. It turns out that the toxicity in the lymph comes because pancreatic enzymes that are in the lumen, they can now get the mucus layer is thinning because of breakdown of barrier defense. And these pancreatic enzymes can get through the mucus layer into the gut epithelium. And there they cause autodigestion. Once they cause autodigestion, then the same pancreatic enzymes, and we're talking about protease and lipoprotein lipase, can get past the epithelium into the lymphatic channels. And there is fat being absorbed normally, and the lipoprotein lipase will act on the fat to produce free fatty acids. The toxicity of this lymph comes from the two pancreatic enzymes and the free fatty acids. And if you look at the roadmap, after they gain access to lymphatics, they go up through the thoracic duct, dump into the left subclavian vein, and they're into the systemic circulation. They will cause respiratory failure first because that's the first capillary bed they see. They'll go on to make it to the heart and the kidneys where they can cause organ failure. We also now know that there's mitochondrial dysfunction and failure in critical illness. It's both a functional and structural deterioration. And with the structural deterioration, they begin to leak and they release increasing reactive oxygen species. The functional part of this is they hibernate, they shut down because they can't produce enough ATP to do the work the body needs. And this leads to multiple organ failure. In the kidneys, for example, normally it would filter 100% of the blood coming through the kidneys. If the mitochondria hibernate, they will decrease to filtering maybe 60% of the blood coming through the kidneys. Clinically, that looks like AKI, acute kidney injury, and the creatinine will creep up. If you biopsy the kidneys, the biopsies are pretty normal. This is hibernation of the mitochondria and dysfunction. As they recover, they will go back to filtering more plasma, back to 100%. The creatinine goes back to normal and it resolves. The mitochondria are also responsible for fat metabolism. And with the leaking dysfunctional mitochondria, they leak mitochondrial DNA. And mitochondrial DNA act like DAMPs, danger-associated molecular patterns. They're also called alarmins, same thing. And they will bind to those receptors we talked about, toll-like and nod-like receptors, and cause increasing organ failure and inflammation. This graph here shows the higher the level of mitochondrial DNA floating around in the circulation, survival is decreased. These mitochondria hibernate to reduce demand, and because they can't keep up with DNA production, and that contributes to organ failure. But this process can regenerate. And as the patient recovers from critical illness, there is biogenesis and formation of new mitochondria, and they recover their function, and the organ failure resolves. So this is a key aspect of organ failure in critical illness. And we have to take this into account as we design our nutritional therapies. Now, COVID-19 threw us for a loss a year and a half ago. And this disease process is truly unique. And so we have to look at it compared to traditional ICU patients, traditional nutritional therapy in the ICU. This graph down here in the lower left-hand corner was produced by Paul Wishmeyer, and he took a indirect calorimeter, a metabolic cart, into the COVID unit. And he showed that in the first week, patients have an energy expenditure that's very close to what you'd predict with the Harris-Benedict equation. But the second week, it goes up about to 100, average of 124% of the Harris-Benedict. The third week, it keeps going up further to 143% of the Harris-Benedict. This pattern of response is different from anything we've ever seen before. If you look up here, the Kupferson ebb flow phase of injury, we knew that after 12 or 24 hours of injury or insult, energy expenditure went up, peaked, and resolved in 7 to 10 days, unless there was an additional injury. When we replaced that theory with the SIRS-CARS that said there was an initial inflammatory response with SIRS, that initiated a compensatory anti-inflammatory response, or CARS. And again, by 7 to 10 days, all that was resolved. PICS, the persistent inflammation catabolism syndrome that Fred Moore described, said the CARS takes off at the exact same time as the SIRS. They oppose each other, but within 7 to 10 days, they start back toward baseline. But in PICS, they don't quite make it back to baseline. The shape of this curve is different than anything we've seen. And it's made us rethink these phases of critical illness. We think that the acute and immediate post-acute phases should be over roughly in the first week following admission to the ICU. But what we're seeing here is that these first two phases are extended, and the patient continues to become more and more hypermetabolic, and this can go on for 3, 4, 5 weeks. When you look at the pulmonary critical care doctor and the responsibilities they have in treating these patients, it's formidable. And nutrition takes a back seat. In other words, they have to deal with the oxygenation with these patients, and that is so difficult. Once they establish oxygenation and stabilize the patient there, the 3 pillars of therapy are antiviral, antithrombotic, and anti-inflammatory with the steroids. Then they have to deal with the organs are failing, all the time maintaining the safety of the healthcare providers and appropriate utilization of personalized protective equipment. After they've established all those priorities, then they can start thinking about nutrition. But look at what happens as they start to feed these patients, particularly in the patients that are awake and voluntary proning. They have lost their sense of taste and smell. They have poor appetite. Every time they flip them into the prone position or back onto their back, there's a lot of coughing. There's air swallowing on the high flow nasal cannula or the BiPAP masks. These patients can desaturate just talking to you in the ICU. And so they're afraid. There's this unbelievable fear that one aspiration event will be a fatal event because they have no pulmonary reserve. They worry about a leak in the seal on the BiPAP mask if they put a feeding tube in. They think if they add TPN, parenteral nutrition, to the tube feeding, that triglycerides will be worse, that control of hyperglycemia will be worse. And these pulmonary critical care docs will actually permissively underfeed as a strategy to manage the hyperglycemia. And if you ask them to start parenteral nutrition, they say, look, there's no data to support that. And we'll show that in a minute. They're right. The net effect of all of these barriers to nutritional therapy means that in the COVID ICU, they continue to have huge losses of weight, and their risk of refeeding syndrome can go up while we're trying to feed them. It's just ironic. This is the crazy thing. We now know in COVID-19 that this gut-lung axis of inflammation exists. And that balance that I showed you on my early slide is exists in COVID-19. We all are exposed to COVID-19 by aerosolization. So the virus enters through the lungs, but it turns out the health of the gut determines the severity of disease. In other words, if the gut is healthy, barrier function is intact, and the gut can maintain an appropriate but robust cellular and humoral response, the COVID-19 exposure will be contained. It may even prevent it from invading the lungs, but it will certainly help control against exaggerated inflammation and will protect against the process getting to other organs that have the ACE2 receptors and prevent multiple organ failure. On the other hand, if the gut is not healthy, if there's barrier breakdown, particularly in older patients, comorbidities, the gut is not healthy, now the SARS-CoV-2 virus can get through the epithelium, can cause an exaggerated immune response and affect other organs with ACE2 receptors and contribute to organ failure. This graph up here on the right is a version of that slide I showed you with the balance. In other words, in a healthy gut, healthy individual, there's eubiosis, there's a friendly symbiotic relationship with the bacteria. If there's younger age, no comorbidities, healthy diet, probiotics, prebiotics, all those things will help contain the COVID exposure, and you'll have asymptomatic or maybe mild COVID-19 disease. If there's deterioration of barrier functions, there's dysbiosis, which means the bacteria now have an adversarial relationship with the host. There's inflammation, diet is poor, there's antibiotic usage, which knock down the commensal bacteria. Now you're at greater risk for severe to fatal COVID-19. So again, here is the example where the gut can be an accelerator and make the disease worse, or a modulator and help contain or resolve the disease. Now let's move on to the controversy of protein and calories. And when you look at what we do in North America and what we do in Europe, and you guys in Singapore, Malaysia, have got to decide which way you're going to go. In North America, we use simple weight-based equations. Right now, we're using 20 calories per kilogram per day and 2.0 grams of protein per kilogram per day. And we think this is a great, easy way to calculate requirements. In Europe, they say you got to measure and use the metabolic cart and have a very accurate measure of calories, start from there and try to meet those calories day in and day out. Now, I don't think that's true. If we ask the question, do you have to have a very accurate goal? And I think the answer is no. And that was determined by this EAT ICU trial by Alan Strupp. In this trial, interventional patients were goal directed. They measured the cart every day so they knew exactly how many calories they needed. They did a urine, urea, and nitrogen for nitrogen balance so they knew exactly how much protein was needed. They would start tube feeding and add supplemental parenteral nutrition to the tube feeding. The controls got standard care, weight-based equations. They used slightly different numbers, but weight-based equations. And they did not add supplemental PN until after 7 days. At the end of the trial, look at this. 3 different ways they looked at mortality, no difference between the 2 groups. ICU, hospital length of stay, no different. Infectious morbidity, no different. So do we have to have an exact number, or can we just have kind of a soft goal, soft number? And the answer is it does not have to be exact. The next question is, do we have to, whatever number we come up with, do we have to get to that goal, or can we just be close? Now, in America, we say being close counts if you're dancing. It's close is important if you're playing horseshoes. This is a game where you throw the horseshoes. If you get it around the post, you get more points. But if you're close, you get points also. So close counts in horseshoes, closeness counts in dancing. And now I think being close to the goal, but not necessarily reaching the goal exactly, is good enough in critical care nutrition. And that is determined by this study, the Target study from Australia. This study was looking at different concentrations of formula as a strategy to increase the calories that we delivered to critically ill patients. They used a 1.5 concentrated formula in the study patients, and controls got a standard 1 calorie per cc formula. At the end of the trial, the study patients got more calories, 30 calories per kilogram per day, and for sure met exactly their goal. The controls with the less concentrated formula got 21 calories per kilogram per day. Both groups got the same protein. What was the difference in outcome? No different. Survival, organ failure, length of stay in the ICU and hospital, no different. This tells us if you're close, if you're at 70, 80% of goal, that's good enough. Closeness counts in ICU nutrition. This was further supported by this retrospective study by SINGSPEN and Pierre Singer's group in Israel. They're looking at energy provision, calories, starting here at 0 calories. And then as you increase the percentage of goal calories delivered, and this is looking at mortality, the mortality curve is U-shaped. So as you give more calories, mortality drops. But the lowest point, the least mortality is around 70 to 80% of requirements. As you get up to 100% of requirements or begin to overfeed the patient, mortality may actually go up. With protein, there's still controversy between what we do in North America and what they do in Europe. We push the protein dose higher, and we are using a range now of 1.2 to 2 grams per kilogram per day, while we back off and give about 70 to 80% of the caloric requirements. And the reason we're pushing the protein is we think that with elderly patients who are septic, who are laying on their back with no exercise in the ICU, that there's anabolic resistance, that we give them protein, but they can't utilize it as well. And therefore, if we push the dose, there's some evidence that by pushing the dose, they can utilize the protein better. And this is supported by 2 retrospective case studies. This is the SINGSPEN trial that I just showed, but now we're looking at protein versus mortality. As you start from 0 and start to increase the amount of protein delivered as a percentage of goal, you get to 100% of goal, and the mortality is still dropping as you overfeed the protein. We really don't know what the ceiling of protein provision is, and so we are pushing it higher. That's supported by a second study by Allenstrup looking at survival. This is a small or low amount of protein, a medium amount. This is a high amount of protein. There's clearly better survival with the more protein that you push. Europeans don't agree with that. And it's led by this guy, a good buddy, a good friend, Zudin Puthacheri, who is worried about the urea creatinine ratio. And he says, if you push the protein too hard, you're going to get successive increases in the urea creatinine ratio. And the higher the ratio, the longer they stay in the ICU. In fact, as you push the protein and the urea creatinine ratio goes up, this is increasing amount of protein associated with decreasing survival. And the reason for this, he says, that if that ratio goes up, it means that the mitochondria in the muscle are failing and they are producing ammonia because they cannot metabolize. They can't handle the protein that's delivered, and that ammonia creates a toxic effect on the muscles and contributes to deterioration of muscles. He says that effect is associated with post-intensive care syndrome, increasing mortality, and decreased discharge home. You're not going to go back to your home. You're going to go to a nursing home after discharge. So this causes SINGSPEN, the Europeans, to back off and not give more than 1.3 grams of protein per kilogram per day. Now, as I talked to Dr. Tan before we started, we have new guidelines that are about to come out. They're going to surprise you, and I'm frustrated to say it may disappoint you. They didn't redo our 2009 or 2016 guidelines. They just focused on 5 areas that they thought needed to be updated. The lead authors are Charlene Comfort and Carol Braunschweig. And they basically, I'm going to share 4 of the 5 recommendations with you. That's all it is, the new guidelines, 5 recommendations. The first is, does higher versus lower energy intake impact outcomes? And their answer is no difference in outcomes. They suggest you use higher, higher or lower, you pick. And I've shown you on these slides that really is not too crazy. If you're close, that may be enough than meeting 100% of requirements. Second recommendation, does higher versus lower protein impact outcomes? And their answer, there's no difference in outcome, a paucity of data, and they don't make a recommendation. They say you're on your own for protein provision. And as I've shown you in America, we would push it the dose higher. So this is a little frustrating. Now, before we go on to other of the recommendations for the new guidelines, and they've not been published yet. And the reason they haven't been published is the board doesn't know what to do with them. So keep watching for those. Now, we have to ask this question. We've had a decade now of trophic feeding or permissive underfeeding. And this started with the ARDSNet Eden Omega trial, and then the Robbie's permissive underfeeding, the permit trial, in which patients either received 20 cc's an hour versus full feeds, or 50% of goal feeds versus full feeds. They didn't quite get that. But both of these trials, there was no difference in outcome. And this underfeeding of enteral feeding seemed to do just as well that first week as full feeding. Why would that be? And the answer is that this trophic feeding may be valuable because we need to have a slow ramp up in the ICU in those first few days. 5 years ago, I would have said, start feeding within 12 to 24 hours and get to goal in the next 12 to 24 hours. But now we're saying, take it easy and go up slowly over the first 3 to 5 days. And there are 6 reasons for this slow ramp up. Number one is that if you're on vasopressors, if there's any hint of hemodynamic instability, you've got to go slowly so that you don't precipitate ischemic bowel. You can feed, you just have to do it carefully. Second reason is when you're critically ill, the liver is going to pour out glucose, and that's going to be added to the calories that you're delivering with your formula. And the combination of that two can inadvertently overfeed the patient, and we don't want that. So you go slowly. Third reason, if the phosphate drops below the normal level, you have got to worry about refeeding syndrome. And this was shown by Gordon Doig, in which patients were in the ICU, feeding was started, and if the phosphate dropped out, then they randomized them to rapid or slow ramp up. The rapid ramp up, the survival curves separate immediately, and if you push the feeding in those patients, you actually killed the patients. You have to do a slow ramp up. The mitochondria, as we said, are failing. That failure is contributing to organ failure. The harder you push nutrition, the greater the demand you create for ATP, and you will make things worse. And that could actually maybe make organ failure worse, theoretically. Underfeeding supports autophagy, which is going to clean up bad muscle, and that may help with recovery after the ICU. And then the 6th reason is the sicker you are, the more trouble you're going to have with GI tolerance. You need to go slowly to establish tolerance of your feeding. Now, we have to ask ourselves, after 2 recent trials, should we be using more TPN in the ICU in the hospital setting? And this was based on the Calories and the Nutriria 2 study. The Calories trial from England was enteral versus parenteral feeding over 5 days in a group of very sick patients, no difference in outcome. The Nutriria 2 trial was from France, enteral feeding versus parenteral over 5 to 6 days in patients in septic shock, no difference in outcomes. And this would suggest that under very controlled conditions, even in high-risk patients for a short period of time, the outcome from TPN can approach that of tube feeding. That's what it suggests. It really tells us clinicians that we can do TPN safely. And all the other guidelines, including our older 2009, 2016 guidelines, SINGSPEN guidelines, German guidelines, still say that enteral feeding is preferred over parenteral. But for all of us clinicians, it should lower our threshold for adding or going to TPN if we can't get the job done with enteral feeding. Now, let me bring you back to these new 2021 guidelines that should come out from ASPEN anytime soon. Here are 2 more of the 5 recommendations. Number 3 is if a patient in the ICU is a candidate for either enteral or parenteral, does the same dose of exclusive TPN versus tube feeding over the first week impact outcome? And they say there's no difference in outcome and recommend either parenteral or enteral as acceptable, implying that use them interchangeably. Either one's just as good. I don't agree with that for all the things I talked about. Number 4, if a patient is on insufficient tube feeding, does adding supplemental PN over that first week change outcome? and they say, nope, there's no difference, suggest not adding it until after day 7. And we said this in the 2016 and the 2009 guidelines. SINGSPEN says the same thing. And the only problem is COVID-19 is different, and it may affect this recommendation. In fact, the key issue with COVID-19 is that it is a prolonged, they're sicker, longer. So in the past, when we talked about when do you add supplemental TPN to your tube feeding, we said in the 2016 guidelines, we actually made COVID-19 guidelines a year ago for SCCM. We said we would wait 7 to 10 days to add supplemental TPN if you're getting less than 60% of your goal, regardless of their risk. The problem is with COVID-19, it's worse. They're sicker longer. The patients are more unpredictable, which and they may have more prolonged inadequate therapy. So when we go to these pulmonary critical care docs and we say, what's your reluctance? Why don't you add TPN to your tube feeding? And they get a bunch of responses. One is that TPN represents is the same thing as total poisonous nutrition. And I think I have to blame Paul Merrick here. He wrote editorials in which he talked about total poisonous nutrition. Here's the title of one, Death by Parenteral Nutrition. So pulmonary critical care docs have a bad taste in their mouth from reports like this. We've had a decade in which we thought trophic feeding was enough. And I think we've lost some of those skills for tube feeding. In the COVID patients, there's concern for glycemic control. Sometimes there's so many IV medications, antibiotics, pressor agents, antiviral agents, that they can't dedicate access or a central line to TPN. And then finally, the pulmonary critical care doc will turn to you and say, look, there's no evidence in the literature that if I add the TPN to the tube feeding, that's going to change outcome. And guess what? They're right. This is the current literature looking at the addition of supplemental TPN to tube feeding versus tube feeding alone. And there are 3 different categories that you'll find these studies. The supplemental TPN, there's 2 studies. The Parenteral trial was a disaster. The TPN added on day 3 did to tube feeding, every outcome parameter was worse than if they waited till day 8. In the Heidinger Swiss supplemental PN trial, they added supplemental PN on day 3 versus tube feeding alone. The trial said there was a reduction in nosocomial infection, but it wasn't major infection. It wasn't pneumonia or bacteremia or abdominal abscess. It was other infections, nose, skin infections. It was a negative study. In the goal-directed EAT-ICU trial, that I showed you, they had exact goal. They added supplemental PN to the tube feeding, no different from tube feeding alone. And then 3 trials that looked at tight calorie control, a pilot single-center Tychicos, a multi-center international Tychicos, and then the top-up trial from Darren Hyland and Paul Wishmeyer. Each time they would add supplemental TPN to tube feeding versus tube feeding alone, and there was no difference in outcome. In the pilot study from Pierre Singer, there was a trend toward better or less mortality, but every other outcome parameter was worse. And when they repeated the trial, there was no difference in outcome. So if the pulmonary critical care doc says, I don't see that adding supplemental TPN to tube feeding is going to change outcome, you have to come back and say, look, the alternative is this prolonged inadequate nutritional therapy. And maybe in the COVID patient, because this process is going to go on much longer, we need to reconsider adding TPN to our tube feeding. So that means as an institution, if you're managing these COVID-19 patients, I think there are 2 basic strategies. One would be to do small bowel feeding from the start. This means that all your COVID patients, when they come in the ICU, at some point, particularly if they're intubated and go on mechanical ventilation, you got to get the tube down below in the small bowel. You can use the GPS guided or the optical iris tubes. And that way, when they're put in the prone position, the intensivist is comfortable giving the same rate of feeding as when they're in the supine position. If you don't have that expertise in your hospital, then the other base strategy is to start anything by mouth in the voluntary proning or gastric feeding in the patient on mechanical ventilation, and then have a low threshold for adding supplemental PN, maybe within 2 days. That way, when you prone the patient and the intensivist wants to back off on the rate, you can make up the difference with TPN. The point is, prolonged, inadequate gastric feeding alone is just not sufficient. It needs to be reevaluated. And finally, I want to say that the most important aspect of what we do should be whether our nutritional therapy supports barrier function and the microbiome. Now, and this is a paper that my buddy and colleague Bob Martindale and I wrote, and asked the question: do current strategies in nutritional therapy do this? Do they neglect the microbiome? Do they neglect these barrier strategies? We know that tube feeding is associated with less inflammation than TPN. Now, we've known this from animal studies and human studies. The problem is with tube feeding, we tend to use these refined formulas that get absorbed very high in the GI tract, which means that nutrients don't get down to the terminal ileum where all that immune signaling is going on, or the cecum where there's the greatest microbial burden. And with TPN, there are no nutrients in the lumen of the gut. So we actually need to think about strategies that promote commensalism and the growth of the friendly bugs. So judicious use of antibiotics, avoiding opioid narcotics. Opioids stimulate virulence, using probiotics or symbiotics. We need to use soluble and mixed fiber formulas, and we may want to shift earlier than before to blenderized whole food formulas, because they may get down lower in the GI tract where they're needed in the cecum. In 2009, we were really hard on fiber, and we pushed a fear of fiber that in retrospect is probably inappropriate. We said, look, you can use soluble fiber if they have diarrhea, but avoid soluble and insoluble fiber if they're at high risk for ischemia or dysmotility. And the reason we were so scared of fiber in 2009 was because it was the year after the Dutch Parenteral study in pancreatitis, in which the study groups both groups got intrajejunal infusion of prebiotic fiber, mixed fiber formula, and then the study groups got 6 probiotic organisms. The ones that got the probiotic organisms, the mortality was 2.5 times greater. And in that study, there were 6 cases in which the insoluble fiber formula inspissated. That meant it became solid and formed a cast in the small bowel. And this is a picture of 2 different patients where that has happened, in which you get solidified formula in the small bowel. There were 6 cases in the Parenteral study and only 5 other cases in the literature. And this inspissation of formula occurs in conditions like dehydration, dysmotility, hypotension, vasopressor therapy. The same conditions that would predispose to bowel ischemia predispose to inspissation of formula. This is what scared us. The problem is that inspissation is very rare, and it's even more rare than ischemia. These conditions of hypotension, dysmotility, will predispose to both inspissation and non-occlusive mesenteric ischemia or non-occlusive bowel necrosis. We know that the incidence of ischemia is low. In traditional ICU patients, it's less than 0.3%. In COVID-19, it's about double that, 0.7%. The incidence of inspissated fiber is far less. As I just showed you, there's only 10 cases in all of the literature. When you look at ischemia, the number of cases that are linked directly between the delivery of the insoluble fiber and the ischemia are 2 cases of ischemia in ICU patients by this Korean paper, and then the 9 cases of ischemia in the Dutch Parenteral study. We now have arbitrary consensus on when it is safe to provide tube feeding in a patient that's hypotensive and on vasopressor therapy. You've got to hold the tube feeding if there's hemodynamic instability, if you're just starting or you're escalating your vasopressors. But it's okay to restart tube feeding once you're stable on stable doses for 24 to 36 hours of the vasopressors, and you've got a mean arterial pressure that's greater than 60. The question is, as you start your tube feeding, can you include fiber, or do you have to hold back on the fiber? In 2016, we tried to be a little more aggressive with fiber. We said, look, we recommend soluble fiber for everybody. But then we turned around and shot our foot off and said, yeah, but if there's risk for ischemia or dysmotility, you got to back off of both. In fairness to us, I think we made a mistake. We exaggerated that fear. But SINGSPEN and Canadian didn't even comment on fiber, and to date have still not commented on the use of fiber in the ICU. The reason I'm making such a big deal out of fiber is it's very important for our patients. One of the guys that I respect the most in nutrition is a surgeon in Chicago, John Alberti, and he refers to butyrate, which is one of those short chain fatty acids produced from soluble fiber. He calls it the master and commander because of all the beneficial effects it has in reducing exaggerated inflammation. For starters, butyrate is magic on every aspect of barrier function, but it also affects these G protein receptors on macrophages and in the submucosa, and it binds to these receptors and reduces systemic inflammation. It also binds to a thing called HDAC receptors or deacetylase inhibitors, and when it binds to those receptors, it decreases inflammation. And if that weren't enough, butyrate also affects phenotypic expression of macrophages. You can have M1 macrophages, which are pro-inflammatory, or M2. And butyrate produces the M2 macrophages, which are involved in resolution and healing and homeostasis and anti-inflammatory effect. So we really want the benefit of fiber in our nutritional therapy. So when you go back, should we be concerned about the risk of fiber in the ICU? And we need to be cognizant of that risk, but the benefits of both soluble and insoluble fiber are enough to warrant that risk. In other words, if we are comfortable enough that they're stable enough to start tube feeding, then we should use the mixed fiber formula, soluble and insoluble fiber from the get-go. And finally, there are other things that we may do to promote barrier function, to reduce the growth of the viral pathobiome. One is to give them phosphate, and you can't just stick it in the tube. You got to bind it to something like polyethylene glycol that can carry it down to the cecum. This is not available commercially yet, but keep your eyes open for that. There's a product made from cows that's serum-derived immunoglobulin, IgG, that binds to all the virulent pathogens that we worry about. That's a commercial product that can be added to tube feed. It hasn't been studied in critical illness, but has been studied in other cases of diarrhea and irritable bowel. And we've started to see some early cases of fecal transplantation in sick ICU patients that don't have C. diff. And you can think of fecal transplantation as the ultimate probiotic. And in these cases, the SIRS response turned around immediately in 10 to 12 hours. So in summary, we have to ask ourselves, as we go through these phases of traditional critical care, in the initial acute and immediate post-acute phases, we're just sticking our toe in the water, we're initiating formula, we're doing a slow ramp up, we're starting fiber-containing formulas, moving toward whole food formulas as we get later in that first week. We're making sure they get probiotics. We may start using fecal transplantation, exercise, and then hopefully we'll move on into the recovery period. How do we know we're in the recovery period? Well, for starters, the insulin dose drops as a patient shifts from catabolism to anabolism. And with that anabolism, potassium and phosphate may drop as they move into the cell. Also on sonography, muscle becomes darker because now the muscle can make glycogen, which is 3 parts water. That may be a sign that we've moved into recovery. The key is it's not so much how much protein calories we provide to a patient, it's the degree to which we support barrier function and the commensal microbiome. That's most likely to affect outcome. And I've run a little over my 40 minutes, but I'll stop there, Dr. Tan, and move back to you for question and answers.
Wow, thank you, Professor McClave. You made reference to dancing, and I think you really took us through a lot of dancing there. You must be a fan of the Korean pop band BTS. They've got this song, Permission to Dance.
I am.
Dancing there. I think as with dancing, I like that analogy because a lot you went through a lot of things, and I think timing is everything. And as with dancing, I mean, you got to get the timing right. Your steps are not, if not, you look like a complete fool, isn't it? But with timing, I think with the feeding, I mean, when to feed what and how much. And then in terms of the timing of mitochondrial dysfunction and the subsequent recovery, it does seem to me that, the key is when the mitochondria recover, then the body is better able to utilize all the substrates we're giving it, and also have the gut recovery as well. So they're really tied together. And if you feed at the wrong time and the mitochondria is not recovered, the timing is all wrong, isn't it? And the timing is then also very different for different patients. So I think, how do we then decide, in terms of when this ramp up is or not? And is there any clues or signals for us? Because you've told us about, how to do this, but when do we start doing some of this? Any clues for us?
No, these are great points. Boy, you're just hitting those points perfectly, Dr. Tan. And the thing I didn't say is, if the mitochondria are functioning, that's where we metabolize fat. That beta oxidation of fat occurs in the mitochondria. So that really adversely affects our ability to utilize fat. They've already got insulin resistance. They can't handle carbohydrate. They have anabolic resistance. So they're not handling protein or not incorporating protein well. So you have to ask yourselves, what are we trying to do? We're trying to give all these calories and proteins at a time when the mitochondria, we're just going to increase demand. And my answer to that is, I think the most important thing are all these strategies that support barrier function and the microbiome, that we're bathing the GI tract. We are affecting immune signaling. We're trying to affect that dysregulation. We're doing all kinds of strategies to take the bacteria that are trying to become virulent and reversing that back to commensalism. And so that's why the slow ramp up, because we don't need the amount so much in the first. The timing, we have to start very early, within 12 to 24 hours, but the slow ramp up allows us to do these metabolic, immunologic, structural, functional aspects of barrier function. We can accomplish that at lower doses without increasing demand, without stressing the system that's floundering.
Yeah, I think generally all of us in the critical care world have all accepted now that we really do not need to feed patients too much in the first 48 to 72 hours even, because of all those reasons that you spoke about. But in terms of starting, even trophic feeding, do you think that is something that is very important in preserving, our gut microbiome? And in particular, maybe, like, for example, I like to use peptide feeds, especially if the patients haven't been fed for a whole week. Do you think there's any role in such stuff, to help preserve the gut microbiome?
Yes, you're just nailing this. The timing is critical, and you can't wait 3 days to start anything. You got to start the trophic feeds within 12 to 24 hours, assuming it's safe. And you see these things. They've documented with trauma and injury, for example, that within 6 hours, 90% of the commensal organisms are gone, and they're killed by these pathogens that emerge, or they're sequestered in crypts in the gut, or in the tertiary alveoli in the lungs. They're hidden away, or they're outright killed. In pancreatitis, a study by Amori showed that on admission with pancreatitis, they already have increased gut permeability that is linked to organ failure. And if they didn't have it on the day they hit the hospital, within 1 or 2 days, they develop permeability and organ failure. So you're right, this process is starting very, very, in burns, they talk about not just early enteral feeding, but very early feeding, because these gut breakdown occurs in the first 4 to 6 hours following a major burn. So timing is critical. We got to get something started to help utilize the gut and reverse these processes, and get that started, deal with tolerance, go slowly, but don't worry about getting to go so fast.
So can I talk to you a bit about probiotics as well then? I mean, we all feel that probiotics are going to be helpful in restoring the gut microbiome. But I think there are issues with timing again. When do we start them? The type of probiotics, because not all probiotics are the same. And we consistently see different studies that study different probiotics show different outcomes as well. The very recent JAMA study as well, looking at probiotics in pneumonia, reducing VAP in Canada, and the Canadian study showed that there was potentially even harm, just like in perhaps the pancreatitis trial that you mentioned as well. So what is it about the probiotics that are going to help us do this better?
I haven't seen that JAMA article yet, so I'm nervous about that harm that you mentioned. Really, the Dutch proprietary study stands out as an outlier. And it was a wonderful group of researchers. That Dutch pancreatitis study group was a phenomenal group of researchers. They just were too aggressive. Every other probiotic study in the ICU, Maren Colliff's work at WashU in St. Louis here in America, showed a reduction in VAP, a reduction in C. difficile with probiotics. And they're all double-blind prospective randomized trials. So nobody knows if they're getting the probiotics or not. It's double-blind. The negative is what you were alluding to. We don't have a standard probiotic. The patient populations are widely disparate, from septic ICU pulmonary patients to pancreatitis patients to trauma. So they vary tremendously in the patient population and in the probiotics they use. But I see the data as overwhelmingly positive. And in pancreatitis alone, there have been 6 trials other than the Besselink Dutch proprietary study that were all positive for benefit of probiotics. The only thing that makes me nervous, Dr. Tan, is John Alberti, who I just think the world of his research. He says, don't you think it's a little naive to plant one plant in the middle of a bare garden, one probiotic, and think that's going to change everything? We should absolutely be trying to replenish the garden. And that's why I'm excited about fecal transplantation. And there's some danger with fecal transplantation, but they're now talking about sterile lyophilized powder. It's just the pieces of the commensal bacteria. And that's why I made such a big deal out of that. It doesn't have to be live commensal bacteria. It can be their sterile lyophilized filtered pieces of those bacteria. And that could be used as a fecal transplant that would be safe. And the early studies have shown it's just as effective.
So, I mean, if you were to give a takeaway with regards to use of probiotics, what would it be? I mean, do we just grab whatever is available commercially, start it on day one down the enteral tube, 1 packet, 2 packets a day? I mean, there is really such, people want to know, how do I use this thing? Yeah.
That's exactly what we all worry about. And the answer is, just be dedicated to utilizing it. The one caveat is when you do use a probiotic, whatever you decide, you need to swab the oral pharynx, like with a spongy stick, and then put the rest of it down through the tube. That's an important part. Maren Colliff in St. Louis showed that part was very important. And I can't give you an answer. We know that like Saccharomyces boulardii would be the most effective, but it's too dangerous to use in the ICU where you might have an aerosolized fungus and a central line. So you can't use that one. But VSL number 3, Lactobacillus GG, Symbiotic 4000 in Europe is a commercial, very effective one. My buddy Bob Martindale uses kefir, which is like a super yogurt. And so I think we don't need to focus on which is the best of those, other than to say, figure out one that has good probiotic organisms, swab it, put it down the feeding tube at least twice a day, and be dedicated to utilizing it. Dr. Tan, I can't get my docs to utilize the probiotics, and yet the data is very strong.
Yeah, it's still something that people here in this region struggle with as well. Proponents will use it almost all the time, and people who don't believe it, will find excuses not to use it as well. So I think it's something that really needs a lot more attention and sort of people to make some conviction about, I think, and then apply it to the patient in front of you. I think that's something that is key, isn't it? One last question, I think, because time is running out. Again, with regards to fiber, any specific soluble fiber you think that might be beneficial for the critically ill? Hydrolyzed guar gum, FOS, anything, or we just use whatever is commercially available?
I've got a slide with all the different prebiotic fibers, and our enteral formulas have a mix a lot of time of those fibers. I don't have one that stand out in my mind. I remember two of them, and now I can't remember which one actually can act like a FODMAP, which could affect tolerance. But I don't have a particular fiber that stands out. The soluble fiber, we're probably getting a bigger benefit than we are from the insoluble fiber, but both are important. And the bowel regimen, that's where we get from our insoluble fiber, is important. But the big bucks is that butyrate production, which is just absolutely magic.
So maybe one, if I might apply my chairman's privilege, just to extend this one more question, which is the use of indirect calorimetry as a tool, perhaps, to see when patients start to improve. Because, you know, I'm a fan of using it. You know, I agree that reaching a goal, you know, may not be absolutely necessary, like dancing. Getting close and close enough is good enough. But we've seen that as patients start to recover, and if you have them on a continuous indirect calorimetry, like some of us do, where it's really just used continuously with a ventilator, we can see when the IC readings go up in terms of demand. And it's just a signal, perhaps, that the mitochondria is starting to work better. The patients are able to use the substrates better. I'm not sure, you know, whether this might be a signal, you think?
Yes, your comments are fantastic. I'm a cart head too. I love the cart. It sounds like I was trashing the indirect calorimetry, but it's been a big part of my career. It has taught me so much about how the body responds to stress, how it utilizes fuel. And you just made a great point. In COVID-19, everything's different, and they're more hypermetabolic than the rest of our patients, and it lasts longer. And you don't know that with your weight-based equations. So I just did a point counterpoint on the metabolic cart with Paul Wishmeyer, and I said that you don't need the cart. And at the end, I said, but you really do need the cart in certain circumstances. And COVID-19 is one of them. And it just, like you say, you know, you should start to see that energy expenditure start to come down as you enter into the recovery phase. And you might not pick that up alone based on your dose of insulin or the potassium phosphate dropping or the glycogen appearing in the muscle. I think I love the cart. And if it's available to you because it's part of your ventilator, then boy, I'd use it all the time.
Well, I think thank you. And what this session has shown us, that like dancing, there are just so many moves. There's so many unknowns that we need to know more about. And to know more is what will enable us to practice better. You know, and just like studying more moves gives us more permission to dance, yeah? So I would like to thank Professor McClave for your time, and thank all the audience for joining us at dinner time or breakfast time. And we really look forward to more of such sessions. And I want to thank Nestle for organizing this for us. And we really look forward to more of these. And thank you, everybody, for attending. Have a great evening. Have a great day.
Thank you.
Thank you.